Hello, everyone.
Hello,
How are you doing today?
hello.
Hello.
Good.
Hello. How you
Happy
doing, Robert?
Wednesday.
Hello. I'm doing great. How are both of you?
All good. It's super gloomy, very hot in Texas already, and kind of wild that we're already in June. It feels like this year has gone so fast. I don't know how y'all feel, but I'm like, oh my gosh, halfway through already.
No, I agree. It's crazy that it's already like June. The conference is less than 2 months away. The year is going by way too quick, in my opinion.
Totally. Okay, so let's hop in. So excited to see everyone. I'm like rushing us because Dr. Hudak is incredible and a wealth of knowledge, and we have so many questions that are both clinical but also medication based. Dr. Hudak is a psychiatrist and is going to be joining us so that we can talk all things meds, complex cases, clinical conceptualizations, you name it. I'm so excited. And Bob knows that he's a dear friend of mine, but he knows that I call him all the time for consultation and questions because his wealth of knowledge in some of the more complex comorbidities. So OCD and psychosis, OCD and thought disorders, OCD and ASD, and then of course medication is part. So we're just so excited to have you. I'm going to give a little intro and then love to hear a little bit about what made you do this work and why you love it so much. So Dr. Hudak is a professor of psychiatry at the University of Pittsburgh School of Medicine. He's currently the medical director for the Center of Treatment of OCD and Anxiety at Western Psych Hospital. He serves on the IOCDF Scientific and Clinical Advisory Board and has authored numerous articles and book chapters on OCD and is a co-author of the Handbook of Psychiatric Disorders in Adults in Primary Care Settings. He's also the co-chair of the Autism and OCD SIG for IOCDF and lectures on anxiety related disorders in numerous settings. And I know you'll be at the conference this year. And so a lot of folks will get to meet you and say hi there as well, but would love to hear a little bit about just why you do this work and why you're drawn to it.
Okay. I'm always happy to have people come up and say hi and want to meet me, say hello. I think that's great fun. So, please feel free if you're interested. What got me into this work was a little bit by happenstance. After graduation from residency, I was working at the Cleveland VA Medical Center. My job there was to see everyone who came in for an initial intake. And I would just see them one time, evaluate and diagnose them, and send them to the proper clinic, the proper person. Well, one week I got 3 patients with OCD. And I realized there was no one to send them to. I was even told at one point by my boss, the vice chair of the department, that vets don't have OCD, which of course is crazy and isn't true, but it kind of tells you how under-recognized OCD is. And I said, well, I got these 3 vets whose primary problem is OCD, and there's no one to refer them to. Well, I'll keep them myself, and I'll just do it myself. I recruited a social worker there, had an interest in OCD. She went to the BTTI, and we kind of ran an OCD clinic there. And I had that for a year or 2. And then when I came to Pittsburgh already had an up and running OCD partial. At that time, it was a partial hospitalization program, and it was one of the very few in the country. They had someone running it. And I was talking with that psychiatrist shortly after I came, and I talked about my interest in OCD. She goes, well, why don't you take over for me? I don't really like doing this. And she literally handed my keys and ran out the door. And so I've been doing it ever since then. And there we have it. That's why I do it. I ended up with that. But
there you are.
I always tell my trainees that OCD is the best work in psychiatry. The patients are great. You can get people better, but you're treating a seriously mental illness. So you have that intellectual stimulation, but you get really good patients who can engage with you. It really has everything good in psychiatry that you could want. It is treating OCD.
100%. So I would love to hear a little bit about, because I have my own ideas of where I'm like, oh, I call Bob for this and this and that, and so I would love to hear a little bit about what you what you would say your specializations are. We know OCD, we know OCD medication, but do you want to talk a little bit about some of the important work you've done on complex comorbidities and the articles in those arenas?
Yeah, so 2 of the things that I really concentrated on are number 1, comorbid OCD and autism. Being that So that happened a little bit by happenstance. There was a unexpected opening in the autism clinic at Western Psychiatric Hospital about 15 years ago. And they asked me to fill in just simply because they know that I'm someone who's pretty flexible. Most other people don't like kind of changes like that. I said, well, they know that I wouldn't mind working in an area that I wasn't real familiar with. And it was supposed to be a 6-month assignment. And at the end of 6 months, I told my boss and I said, I don't want to leave. I like this population too much. And one of the things that happened as soon as I joined the clinic, somehow word got out in the greater community that I was there. And so everyone who had a developmental disability who also had OCD said, oh, now's our time to get in and get treatment for the OCD. And so I was getting all kinds of comorbid autism, OCD, and intellectual disability OCD patients. And that was part of the reason I didn't want to leave. I had all these great patients, but then I looked at the literature and there was so little written about this population, and what was there was pretty bad. And I said, well, I want to do something to help advance this. And we formed the Autism and OCD SIG. We have a very active board. We've done a lot of things with that, and I'm pretty proud of the work we've done so far, and we continue to do. We just met on Monday, and we have new initiatives that we're planning now. So we are, we're still moving forward, and I think the work that is being done through IOCDF on autism and OCD is great. As far as my interest in OCD and psychosis, that is relatively easy to explain. There was a Closereau clinic when I was in the Cleveland VA, and there were a few patients there who didn't have schizophrenia. Closereau is used for treatment-resistant schizophrenia. I saw some of these patients said they don't have schizophrenia at all. They have OCD, and the reason they're treatment-resistant is because. The reason they're treatment-resistant is because, well, they don't have schizophrenia, so of course they're not going to improve with schizophrenia treatments. And through the years, I've seen numerous patients with OCD who have been misdiagnosed as schizophrenia. I mean, OCD gets misdiagnosed as bipolar all the time. It gets misdiagnosed as schizophrenia. Sometimes it gets misdiagnosed as anxiety disorders. But the schizophrenia and the bipolar especially are really difficult because the treatments are very different, and the treatments carry a lot of comorbidity with them. So I just had that special interest in trying to define the difference between OCD and psychosis, and to help with other clinicians better able to distinguish between the two conditions so that patients get a proper diagnosis and proper treatment.
100%. And we are go ahead, Chris.
No, I was just going to say, can you talk a little bit about rates of comorbidity? Because I think a lot of times what I see in sessions is a lot of people experiencing some shame or stigma because they're already struggling with OCD, but they may also have autism or, BDD or OCPD, et cetera. So when your years of working with OCD, do you often see comorbidity? And is that kind of the norm? Because I see so many clients that already feel shame around having OCD, and then they feel like shame, and I have this other thing as well, and they feel different.
Well, it's a little bit funny. I tell residents all the time, my trainees this all the time, I rarely diagnose OCD because, of course, patients come to me because they know they already have it. So it's unusual that I get a chance to diagnose someone with OCD where the diagnosis is unknown. Not never, though. I do it occasionally. But so that is less of an issue for me. Most of the people already are coming. They're coming with multiple diagnoses. I see, again, just my personal experience, I see the stigma being attached more to OCD than other things. People are, they have that rational part of their brain where it says, I know these symptoms are silly. I know these thoughts are silly, but yet I can't control them. And it seems to be the OCD tends to cause more shame than the other symptoms. So comorbidity, very, very common. We rarely see someone with just OCD. Even when we see someone with just OCD, they more often than not, will have one of the OC-related disorders, hair pulling, skin picking, body dysmorphic disorder, or hoarding. So again, comorbidity is very common. I really see people, they're more willing to talk about depression and anxiety than they're willing to talk about obsessions and intrusive thoughts.
Yeah, 100%. And I would love to hear a little bit, because I guess a question I have now is, how often do you see the comorbidity of OCD and a thought disorder? So like OCD and schizophrenia versus it's OCD that's being misdiagnosed as schizophrenia, or it's actually schizophrenia or a thought disorder that's being misdiagnosed as OCD?
Well, if you want good scientific numbers, I don't have a lot for you. Okay. So the rate of
That's okay.
schizophrenia in the general population is 1%. We know about 1 in 100 people have it. The rate in patients with OCD with schizophrenia is probably going to be pretty similar. So I imagine that probably about 1% of people with OCD also have schizophrenia. However, flip that around. What's the rate of OCD in patients who already are diagnosed with schizophrenia? And those numbers vary wildly. I've seen as low as 5%, as high as 50%. It's probably somewhere in between, but it is very common for people with schizophrenia also to have OCD. So those numbers, they're pretty common.
Okay. So, I don't know where to start, but I want to start with complex comorbidities because I have so many questions and love this arena. And then we'll hop into medication because we have so many questions around that. So, I guess one of the first questions I have, and this has actually been brought up quite a bit in some of our recent live streams, and I'm just going to read it because somebody recently submitted this question, and I think it's a really good one that you could take on, is schizotypal personality disorder and OCD both present with weird thoughts and weird behaviors. What is the difference? In case somebody being affected with both, how would it be treated? So how do you differentiate schizotypal and OCD if it's both bizarre behaviors?
Okay, so there's a lot to unpack. That is actually a very good question. It's actually a fairly complex question. So number one, I will say that the comorbidity of schizotypal personality and OCD is one of the things that have been shown to make OCD more treatment resistant. Okay, so
if somebody has a comorbid,
if somebody has this particular comorbidity, it makes their OCD tougher to treat. Okay, so that's probably the first thing I should say. I do see schizotypal personality disorder misdiagnosed as schizophrenia quite a bit by mental health professionals. So we probably should define what is schizotypal personality. And these are people that have odd or unusual thoughts that aren't necessarily consistent with the general population. These aren't delusions. So a delusion that you see in schizophrenia is a false fixed belief. These aren't false fixed beliefs of things that aren't true. These are just weird ideas. Think about if you're familiar with the show Seinfeld, think about Kramer. Kramer was one of the best fictional examples of schizotypal personality disorder that you're going to want to see. There was a whole episode where he believed that they were experimenting on people and turning them into pigs. And he was running around the city trying to look for pigmen. There was another episode where he found the set of the Mike Douglas show, and he set it up in his living room, and he decided that everyone coming into his apartment should act like they're on the Mike Douglas show. So again, not delusional. He's not delusional in any of these cases, just kind of these weird beliefs that other people don't have. You can describe it as people, who believe in, UFOs. It's not just believing in UFOs, but believe that, hey, maybe they're walking around here all the time, and they meet with me and other things, and sometimes it's been described in that way. So again, weird beliefs that aren't delusional. Nothing really to challenge as false or fixed. So like the idea that everyone has to act like they're on the Mike Douglas show. That's not there's not anything that's true or untrue about that. It's just kind of a weird opinion that other people don't have. The idea that pigmen are running around New York. Again, it's just a weird idea he has. It's not really something that is verifiable one way or the other. In fact, at the end of the episode, he realizes that there aren't any pigmen. Where it gets difficult to treat this with OCD is that sometimes people with OCD will have these strange thoughts about their obsessions. And so the obsessions aren't entirely intrusive at that point. There's a certain amount of odd ideation and belief with it, that, again, makes it harder to target with medications and definitely harder to target with ERP. And the best example I can give that to you is I have one patient who has a fear of germs and contamination, but also believes that germs intentionally target him, believes that germs are out to get him and want to contaminate him and want to contaminate his stuff. And so that is a good example of the schizotypal type of thought, this weird thought, germs are out to get me. And obviously it made it really difficult to get him to challenge his contamination with ERP, because he said, well, they're just going to target me anyway, so why should I do the work? Okay, go ahead.
No, go ahead.
I was just going to say, your part two of the question is, how is somebody being affected with both? How they should be treated? I'm going to tell you that, and you're going to probably hear this a lot today, they're going to be treated with OCD meds and exposure with response prevention. I don't think there is a whole lot else that you do to treat them. I think with schizotypal personality, we use antipsychotics sometime, I think with not really good results. I think you can do some cognitive work and challenge some of their thoughts might be the best thing to do. Really, I think that a good CBT therapist can challenge, and the person says, regardless of the thoughts, can you do the ERP? I think that is using that type of motivational stuff to get them to do the ERP. I think that's where it's going to be a little bit different.
I guess I want to add on really quick to that. Sorry. So what then would separate OCD schizotypal versus a true thought disorder like schizophrenia? So what is the difference between schizotypal versus schizophrenia?
Okay, so the difference is, again, the people with schizotypal just simply have these odd opinions, these odd personal beliefs, whereas people with schizophrenia they have three things that make up a break from reality, a thought disorder. There's false sensory perceptions, in other words, hallucinations. There's a thought disorder, in that their thoughts don't work. Their thoughts don't flow evenly like other people do. You don't go from A to B to C to D when you're thinking. You can go from A to D to B to F to Z back to Q. Your thoughts can go all over the place. And the third thing where it gets confused most often is delusional. But again, there's a difference between an odd belief and a delusion. So a delusion would be, aliens have implanted a chip in my brain and are controlling me. So there's nothing about that that's an opinion that I want everyone to act like the Mike Douglas show, and I have this weird opinion that no one else has. I want to be prepared for when aliens come and land in my backyard, and so I've made a landing strip so the aliens will visit me. Think about Linus and the Great Pumpkin. I believe that the Great Pumpkin will arise out of the most what does he say, the most pure pumpkin patch, or most sincere is the word he uses. So these are just kind of odd opinions that people have. This is different than saying, yeah, there's a chip in my brain, and no matter what you do, no matter what you can do all the head scans you want. If you don't see it, that just means they're really good at hiding it. There's nothing you can do to disprove.
And I feel like that's a big differentiator, correct me if I'm wrong, is that individuals with OCD are trying to find anything to disprove this, right? So people with OCD, you have this intrusive thought, you want reassurance or some sort of confirmation or whatever it might be to make sure this isn't true, right? So I want to call my mom to make sure she didn't get hurt. I want to, rewash to make sure I don't contaminate someone. Versus if it's a thought disordered intrusive thought, it feels like all the behaviors and or the evidence that other people provide further confirm to that person that this is true. They're not necessarily trying to disprove it.
Yeah, so clinically, that's a nice way to distinguish between the obsessions, the schizotypal thoughts, or what we would call an overvalued idea, and a delusion. So people with OCD, again, they want evidence that something is or isn't true, and they'll keep asking for it over and over again. The person who has an overvalued idea or is schizotypal, you present them with contradictory evidence, they'll just simply deny that. There's no such thing as the moon landing was fake. There was no such thing. Well, here we have pictures of men on the moon. Photoshop. And no matter, here's a moon rock. No, it's all fake. So no matter what evidence you give someone that it isn't real, that their beliefs aren't real, they just simply reject it. Whereas people who are delusional, they will actually incorporate evidence that contradicts them into their own delusion. So what I mean by that is a nice example. I had a patient who had the belief that cameras were spying on him everywhere. And he believed that there was a camera in the air vent. And I said, you know what? I'll get maintenance here right now. We'll get a screwdriver. We'll unscrew the vent and we'll look and I'll show you there's no cameras in there. And he said, they'll know you're coming. They'll remove the cameras because they know we're going to look. And as soon as you put the cover on the air vent back, they'll put the cameras back. So the evidence that his delusion is wrong is actually incorporated into the rest of his delusion. So again, that's what a delusion, that's what a psychosis is, a thought disorder.
I really appreciate it because I think that's really, we get that question a lot, and it's really helpful for folks to be able to understand and differentiate. And I think that I actually see both. So I see a lot of times where there actually is a thought disorder, but it's being overlabeled as OCD, maybe by family or friends. And I get that because it can look like OCD, where I think what you're saying, which is really true, is it actually might be both, right? And so what we do know, though, correct me if I'm wrong, is that if there is a diagnosed or a thought disorder that's even undiagnosed, you would need an antipsychotic.
Correct, yes.
And so talk a little bit before we jump into all the OCD med questions about antipsychotics for OCD, because we're seeing lots of individuals, I am, kind of easily prescribing, oh, we'll augment or we'll add on an antipsychotic, even though it's clear OCD. And I just really want to hear a lot. I was kind of picking up when you said, okay, thought disorder, antipsychotic, schizotypal, you might add that in, but actually like good old OCD treatment is really what's going to be most useful. What about OCD alone, and where do antipsychotics come in?
Okay, I'm going to say something a little bit provocative, that antipsychotics do not work on OCD and should not be used. Now that's mildly provocative because some people are going to see that and say, well, wait a second, I've seen plenty of studies that show antipsychotics work in OCD. Well, the difference is antipsychotics can work in OCD as augmentation. In other words, if you add them onto already properly prescribed OCD medication. The difference is that most of the time when I see people come to me and they're on antipsychotics, it's not being used as augmentation. So they're on a tiny little bit of an anti-obsessional, let's say fluoxetine, they're on 20 milligrams, and then they get placed on an antipsychotic. At that place, you're not augmenting the OCD med because it's not being maximized. You're using it as primary treatment. It does not work in that way. For augmentation, we've had this discussion here recently. There aren't consensus guidelines on this, but I think more and more of the psychiatrists are kind of coming around to this particular viewpoint, is that we really reserve antipsychotic augmentation like third or fourth line. In other words, we don't use them often. There are a lot of medications that we have that are a lot safer that I go for first for augmentation prior to antipsychotics. And again, I think more and more of my colleagues are realizing that's probably the best way to go, is antipsychotics have a great morbidity and potential harm with them.
I love how direct you are, because it helps us just have these take homes of like an antipsychotic alone is not treatment for OCD, right? Like that's Correct. Not the medication you should be using. But if it's augmented, that means it should be tried later on, but it also means you should be on full dose of effective OCD medication first.
Right. If someone's on a small dose of OCD medication, that is not augmentation, that's primary treatment.
So let's jump to full doses. So let's talk a little bit about that, because I think people get really confused about what is a full dose? What does that look like, right? My primary care put me on this much, when really like the psychiatrist that's OCD specialist is saying that's actually not enough. What is a first line full dose, including dosage for OCD treatment with a SSRI?
Again, they're much higher than when you use the SSRIs for other purposes. And I think that's the point that we need to do a better job training psychiatrists, is that using, for example, sertraline for depression is different than using sertraline for OCD. And psychiatrists tend to think of all as, I know how to prescribe sertraline, I prescribe it one way. In reality, you prescribe it different ways for different things. So The issue comes up where is the maximum allowed prescribed dose by the FDA for sertraline is 200 milligrams. However, for OCD, we prescribe it for up to 400 milligrams. That 200 milligrams for the maximum prescribed dose isn't any magic number. It doesn't mean anything. And I think that too often clinicians, pharmacists think that somehow a magic number that means if you go above it, it's dangerous or toxic. In reality, it's just simply an arbitrary number that the drug company chose. And it's completely meaningless. This maximum dose is completely meaningless. So we go twice the maximum dose to treat OCD. So for fluoxetine, we go up to 80 milligrams. For Paxil, we go up to 80 milligrams, even 100 milligrams, and that is above the maximum dose. I should say with fluoxetine, sometimes it goes as high as 120. So again, that's above the maximum dose. Fluvoxamine, we go as high as 450 milligrams, which is again above the maximum dose. And with escitalopram, we go 40 to 60 milligrams. And again, that's 2 to 3 times the maximum dose.
Wow. This is so helpful. I feel like I want to can we write that down, screenshot it and put it somewhere just so that folks who, because, I want to be really candid and clear that a lot of our viewers don't have the accessibility to an OCD specialty psychiatrist, right? And so they're going to general practitioners, they're going to nurse practitioners at times, and they're not always able to see someone who really specializes in it. So you guys kind of bookmark that and make sure that you're really talking to your prescribing clinician about, are you on the max effective dose for OCD? And I know IOCDF and other places have some really great articles and resources on this.
IOCD
Chris, I'm going to throw it to you.
Yeah, Rob, I'm going to jump in, and we have so many pre-submitted questions. So the first one is, what is the best med for OCD? And does this person has moderate OCD, does the med depend on severity? So obviously that's a big question, as you just listed off the proper dosage for OCD for all these meds. But let's say I'm going in and seeing a psychiatrist or a prescriber to get medication. Does it matter severity? How do I decide, or how does the psychiatrist decide what is the best med for OCD?
Okay.
For that
So
person?
Best med for OCD is basically any of the SSRIs. None of the SSRIs have been shown to be better than any of the others. And so we choose them based on family history. So if you have a family member that has responded well to a medication, we're more likely to choose that one. We'll choose it based on side effect profile. If you're someone, let's say, for example, you have a particular issue with diarrhea, I'd probably be a little less likely to use sertraline, which tends to cause diarrhea. You will look at drug interactions. So certain medications that you're on, I may say, maybe this SSRI isn't as good. We'll try another one. Other than that, to be honest with you, there is no way to tell which SSRI is the best med for you. And it literally is just like throwing darts at a dartboard. You just have to guess. And if one works great for you, great. If it doesn't work, well, we take you off of it and we try another one. And sometimes we have to cycle through many of them. I've seen people fail 5 SSRIs, blatantly, completely fail, put them on number 6 and they respond beautifully. So there is no best med. Now there's one exception to that. Clomipramine is a tricyclic medication that acts like an SSRI. And there is some suggestion that it might be a little bit better than the other SSRIs. We don't know, but it might be. It was never really proven. Because it has some difficult side effects, the recommendation is that we don't use that first line for OCD. We use one of the other SSRIs first or second, and we really reserve clomipramine as a third-line medication.
You talked earlier about doses, and a second question somebody asked, are doses of sertraline and other SSRI weight dependent? So I guess to expand that question, age, weight, height, sex, are those factors in the dosage you talked earlier? Or is it pretty much like these dosage regardless of height, weight, etc.?
Okay. Just to quickly answer part 2 of the other question. Severity, severity has nothing whatsoever to do with the medication. There is no medication that responds better for a mild or moderate or severe OCD. So the medication protocol is the same regardless of severity. Are the doses of the medications weight dependent? No, the answer is probably not, surprisingly. Many people think that, well, if I gain 50 pounds, do I need a higher dose? Or, if a 100-pound person comes in versus, a 250-pound person, well, you know what? Our brains weigh the same. I don't care what the medication is doing in your body per se. We want the medication to get into your brain. And everybody's brains pretty much weigh the same. So that's where the medication's active. And so weight dependent, no, not really.
I was told I have a super heavy brain, and that's why I'm so intelligent, Robert. So
then you're going to need a lot more sertraline than the rest of us.
Triple. They were like, we need to just pump it in you because you're so brainy. Totally happened. The next question was pre-submitted. Do SSRIs help with OCD and compulsions? I'm on week 2, but my OCD and anxiety has gotten worse and more depressive. When will I start seeing results? I kind of wanted to focus more on the second part because I think you answered the first part, but what happens if somebody's feeling a little bit more anxiety or depressive, and when can they see results, do you feel?
Yeah, so well, meds do work for obsessions and compulsions, especially obsessions, and the ERP is really where you get the compulsions better. A lot of times people do report that they get a little bit worse at first, or sometimes even a lot worse at first on starting a medication. We don't really know why that happens. There's a lot of guesses about why that might be. I think one of the things that tends to happen a lot is that people with OCD tend to be what we say somatically preoccupied. In other words, they're just very aware of side effects and concerned about side effects. So if you focus on it, you're more likely to notice it or perhaps even get it. Interestingly, my patients with intellectual disabilities in my clinic who aren't really focused on side effects, I'll describe it to them, but it's not really a big concern of theirs. I rarely get side effects with them. So I think there may be a little bit of that somatic preoccupation. But again, the data isn't clear on that. There actually may be there may be something to the fact that these meds can make you anxious. Sometimes they can do that as a side effect. We call that akathisia. That is a little different than just causing anxiety, but akathisia is a feeling of restlessness, like I can't sit still. And there's specific treatment to make that particular side effect go away. But if you're only on a medication for the second week, basically you do your best with your psychiatrist, ride the side effects out, and then increase the dose. It can take 3 or 4 months for the medication to start to kick in. Some people kick in early within, 3-4 weeks. It can take up to 12 weeks or more for the medication to start to kick in. And by the way, that's 12 weeks at the maximum dose. So if you're only on week 2 of a medication, you probably aren't on the maximum dose yet. So in a sense, the clock hasn't even started yet.
So before I jump into more questions, because I got a couple pulled up, how long do people need on maximum dose before they start to think about augmentation and other options?
A minimum 12 to 16 weeks.
On max dose?
Yes, on max dose.
All right, you guys hear that? I know that's not fun. I know that's a lot. That feels like a really long time, but 3 to 4 months. All right, first question submitted today at 11:04 from Amy, and I apologize. I'm sure I will mispronounce a little bit of this. So Sydenham chorea is associated with rheumatic fever, has been reported to have OCD associated with it. Do you know if that's true? And if so, can that affect DNA?
Yeah, Sydenham's chorea is a type of a neurological disorder that's associated with streptococcal infections. And there are some there is some OCD that can be associated with streptococcal infections, particularly PANS, pediatric associated neuropsychiatric syndrome. Sydenham's chorea is not PANS, but it's very similar to that. If you do have Sydenham's chorea in rheumatic fever, again, you need to see a good infectious disease specialist to get that treated, as well as a neurologist and probably a cardiologist as well. If there are OCD symptoms, sometimes the regular rheumatic fever treatment, antibiotics, will make it better. Sometimes you need to see a psychiatrist. Okay, these are caused by bacteria. It doesn't affect your DNA at all. Okay, so this is caused by streptococcal bacteria. no DNA effects.
Awesome. Very helpful. Lots of other questions, just reading through them all. Love hearing some of you guys are going to treatment for the first time. Yeah, some folks are talking a little bit about their own experience. Chris, do you want to hop to pre-submitted? Okay, I've got a question. Sorry, I'm here now. First question, 1132. I've been on 250 milligrams of sertraline for a few weeks after being at 200 for over a year. Diarrhea won't stop even after a few weeks. Would it make sense to switch to something else? I've been on one other SSRI that did not help at all.
Yeah, I saw that. And if the sertraline is helping, I'm usually reluctant to take people off of it. But occasionally this diarrhea can be tough with sertraline. There is no doubt about it. I've tried lots of treatments for it before. The only thing I've ever found to be helpful with it is using like over-the-counter Imodium. Unfortunately, I've tried like probiotics and none of that seems to work. If you take it with food, you should always have take the sertraline on a full stomach. That may help the diarrhea, but assuming you're already doing that, other than using Imodium, there isn't much that can be done for that. And so I think if it's up to you to discuss with your doctor. If it's helping and you want to put up with the diarrhea and hope that it gets better over time, and it might, you do that. If the sertraline isn't helping at all and you've been on another SSRI that you were on a good OCD dose and didn't help, well, you have a bunch of other SSRIs to try that don't cause diarrhea. You know, I think when I'm discussing with my patients, I really leave that up to them. You know, if the med's working, we can deal. You know, do you want to put up with the side effects? I'll deal with that the best I can. So with diarrhea, one I can't do much about. I can do a lot about other side effects. Or do we want to try something else? And I make that decision, and I really let the patient be in the driver's seat.
Totally. At 11:33, they said they were wondering exactly what part of that thought that you had, the example you gave around mask and poison food, made you think about comorbidities and why.
I don't know if I said anything about mask and poison food.
I don't either. I think there was the example you gave about the germs. And I can't remember.
Germs, yeah. The one patient had germs attacking people.
You know what it was, Robert? There's another person named Robert in the chat who was saying that their intrusive thought was that, you know, if I go to a restaurant and I'm wearing a mask and someone doesn't agree with mask wearing, my fear is they're poisoning my food. Could that be a comorbidity or could that be part of OCD?
Well, okay. Well, I will say this is something I hear and I see a lot. People with OCD, they have the thought that if they offend somebody, that person is going to harm them.
I had that.
Yeah. So that's a pretty common OCD worry.
Yeah, I had it where I was in my driveway listening to a radio show, like a radio show. I sound like I'm 80. A podcast. I was listening to a podcast in my car and I fell asleep. And a neighbor had called the police and they knocked on my window and I was groggily, not very nice to the police officer, and, you know, showed him my ID and was like, this is my house. I just fell asleep in the driveway. But I wasn't nice. And I remember I ruminated for like 3 weeks. What if they poison my water? What if they arrest me for no reason? You know, it was just like that kind of thing. And I knew it wasn't logical. But OCD never is, right?
Yeah. It's a common obsession. I see it all the time.
Yeah. Next question at 11:36. What are your thoughts on ketamine? It really helped me with depression and OCD. So get this question a lot and we'll go to TMS next, but let's start with ketamine and your thoughts around ketamine for OCD as well as depression, but maybe we can separate them a little bit.
I think the evidence for depression and ketamine right now is much better than ketamine and OCD. And so I think that is where the evidence seems to be. The big issue with ketamine, as there aren't any established protocols for either condition, quite frankly, and most of ketamine clinics aren't run by psychiatrists; they're run by anesthesiologists, and so they're not really mental health based. Not that you can't get better, or not that you can't get improvement with them. But that as a psychiatrist, I've never referred anyone to a ketamine clinic because again, it's all very idiosyncratic. I don't know what you're getting. I don't know what you're going to get. Now, there is a new version of ketamine called S-ketamine that can be given in a doctor's office, can be given by a psychiatrist, that seems to be very good for treatment-resistant depression. No evidence with it in OCD, but for depression, seems to work very well.
Yeah, and so I do see that. I feel like at times when there is new treatment, sometimes we like grasp onto those. And so I just want to give that disclaimer and recommendation that, again, for OCD, it's not evidence-based currently, right? There's not research for it. And so it's really important that you try first-line treatments before you try something that's experimental, versus there may be a lot of evidence for depression. So I think, and important to note that also, if it does work for your depression, it might help your OCD a little bit too, because if your depression lifts, your OCD might lift, right? In different ways.
Yeah.
So let's
Ketamine
jump
is
next.
studied for OCD, but as of now,
It is, yes.
Evidence isn't it.
Not there yet, right? So that's important to note. And y'all hear us talking a lot about that. I just want to like hop back for a second, is that we talk a lot about all sorts of different interventions, but you guys hear us like behaviorally, we are always talking about and promoting and pitching ERP, because to date, it is the most researched and evidence-based behavioral intervention for OCD. But, a lot of folks will ask us, what about ICBT? What about, EMDR? What about other things? And the answer is like, even ICBT, it's being looked at, and it may be a promising intervention, but right now the research isn't at a place where we can say, this is a frontline intervention, this is a gold standard intervention. And so medication actually follows the same route, right? Like there's evidence-based interventions for both behavioral and medication interventions for OCD, anxiety-related disorders, all of the above. So I want to hop to a question that's not on there, but I want to ask the same about TMS. I got asked that yesterday, but where does TMS fall right now in the OCD treatment realm, and what is research and everything else saying about it?
There is a specific type of TMS that is used in OCD called DTMS or DPMS. So most of the machines and most of the TMS machines out there are for depression. Those machines do not work for OCD. You need a different coil or a different technique to help with OCD. So the evidence out there for DTMS in OCD is pretty good. And it does seem to work, and it helps a lot of people. As of right now, I don't think there's any necessarily consensus on when is the right time to refer someone for TMS. Certainly if you fail SSRIs, can't tolerate SSRIs, those are all reasonable times to refer someone for TMS. Yeah.
I have a question. I actually heard of someone recently who had been doing TMS treatment for quite a long time and had not seen results. How long do you need to give TMS? Like if you're trying deep TMS for OCD, do you know how many sessions you would need to give it to see if there's results? Like obviously we wouldn't expect it at the first session.
Yeah, no, you don't get it in the first session. You do like 4 or 5 sessions a week, and you go for a number of weeks. And I'm going to have to apologize. I just can't recall off the top of my head what a typical trial is considered, how long that is. Interesting to note, though, that during DTMS, one of the things that you do as part of the procedures, the patient does kind of like a mini exposure.
Yeah.
Yeah, I just had a client do a Stanford study where it was the quicker TMS like that. And they contacted me, and we did set up kind of like an exposure plan to do while they were doing TMS. I have another pre-submitted question, and this one is one that, I think we all get a lot, Liz and I. Do I have to take medication for the rest of my life? And I would add to that question, how do you know? When do you know it's time to maybe go off? Because there was a second question about weaning off of medication.
Okay. Well, I always tell my patients this. I kind of have a standard spiel about this that I do. OCD is a chronic illness. It's a lifelong illness. It's going to be with you the rest of your life. So do you have to take medication the rest of your life? Well, you're going to have OCD the rest of your life. Fortunately, our OCD medications, especially the SSRIs, are really very safe. So being on them long term, not really an issue. Medications like fluoxetine, sertraline, they've been out for over 30 years. We know everything about these medications, and we know that there aren't any long-term harmful side effects of being on them. Having said that, I don't know where the state of science is going to be in 10 years from now. So I usually tell my patients that don't think of it as taking medications for the rest of your life. Think of it as taking it indefinitely, because rest of your life today, but I don't know that I'm going to say 10 years from now, the rest of your life. So think of it as indefinitely, not the rest of your life. There is something you have to be aware of. When people with OCD want to stop their meds, sometimes if the OCD comes back, it's more treatment resistant. The same medications don't treat it. So for example, if your Y box is a 12 on 80 milligrams fluoxetine, you decide to go off of fluoxetine and you get, a Y box of, 25, we put you back on 80 milligrams of fluoxetine. Maybe your Y box only goes down to a 15 or 16. It doesn't go down to the 12 where it usually is. I see that all the time. And our OCD docs see that all the time. So there is a risk to going off of medications, is that your illness may become a little more treatment resistant.
And you kind of answered Matt Bannister's question at 12:36 about, what would be a good time frame to wean off completely. I know in my own care, my psychiatrist said, let's wait about a year of like little to no symptoms, and then we'll start to wean down. Is that kind of, industry standard, or how does somebody know, hey, I'm doing really well,
Yeah, again, probably not really an industry standard, but I'm willing to bet if you asked all of us, we'd all say pretty similar answers. So I say, yeah, you should be stable for a year prior to trying to go off meds. And then if you do go off meds, you go down very, very slowly. Sometimes I take 6 months or more to lower someone's meds.
Mine was 6 months, yeah.
Yeah, that will help reduce the risk of a relapse. And then the second thing to do when you're lowering meds, you should be an active ERP. Notice how it always comes back. We talk about meds, but it always goes back to ERP. If you're going to lower meds and you don't want to get sick again, you should be actively doing ERP.
Yeah, no, I saw Dr. Fusner, who's a psychiatrist, and like these talked about the year, went down slow, ERP still, and then just general wellness in life. And I don't know if you see this, Dr. Hudak, but the times that I see clients not have a good process of going down on meds is typically if they do it on their own without their psychiatrist's guidance, or it's like they want to go off tomorrow and they go a lot quicker. So I'm glad that you kind of brought that up, because, a lot of times people will be like, I'm feeling great, I'm going to go off myself. And we're always like, Liz and I are always like, no, talk to your psychiatrist, please do it as like a plan. So
I have a saying that I tell my patients. I recommend strongly that you do what I tell you to do. If you decide that you don't want to do what I tell you to do or what I recommend you doing, that's fine. But do it in the way that I recommend. Okay, so if you decide you want to go off on your meds on your own and you're going to do it regardless of whether I say to or not, well, then, okay, that's your choice. But I'm going to tell you how to go off your meds against my advice to maximize that. So again, you can go against my advice, but use my advice in going against my advice.
I love that. Matt asked another question at 12:38, and I think this is one I hear a lot as well. So I thought it was a good question. Is there medications that can be integrated with like an SSRI, for instance, to help possible side effects like insomnia? So if somebody's having insomnia, or I'd say the other one is sexual side effects, like is there medication that we can use to augment if that SSRI is doing really well for them and they don't want to go off completely?
Absolutely, and this kind of relates a little bit to someone asked earlier about the side effects and talked about feeling anxious and depressed the first couple of weeks. There are medications that can deal with, or other treatments that can deal with most of the side effects that you might get. As I mentioned, diarrhea is one that I've had a hard time with, except for using over-the-counter medications, antidiarrheals. I haven't had much success with. But insomnia, sexual side effects, the opposite, sleeping too much, feeling too tired, feeling dulled, or feeling a little bit flattened in your emotions, weight gain. There are medications that I can help you with to treat all of those side effects, or at least to manage all those side effects. So just because you're getting a side effect does not mean it's not the end. Doesn't mean you have to stop your medication. A good psychiatrist who knows how to do this knows how to manage these things.
I'm going to ask this next question to both of you, and I'll have Liz take the behavioral part and you, Dr. Hudak, the medication. Steve says, so my daughter's on the max dose of clomipramine for ERP, clomipramine with ERP. Her OCD is on the severe end of the spectrum. Have you seen the whack-a-mole effect with patients of severe OCD? OCD gets better in one area and then presents in a different one.
Do you want to discuss that
first?
Yeah.
Sure. Yeah. Happy to discuss it. I think that we hear this all the time. We hear people talk about their OCD feels like this game of whack-a-mole. They address one symptom and then another one comes up, and people will say things like, it makes me feel like I shouldn't do ERP at all because the second one, they wish they had the first one instead because that one wasn't as bad as this one. What I tell folks is that if you are doing ERP in this way, or this is how you're experiencing it, you're actually using ERP to function instead of ERP to get you to freedom. If we are actually addressing core fears and using ERP to get freedom from our illness, it should not keep shifting. It shouldn't keep switching. It might try to give you a sticky thought at times, or to give you a thought that kind of makes you jump a little bit, but you have the tools and the ways to not empower that and for it to never become a trigger, for it to stay a thought. But what I will say is that if you find your OCD keeps shifting, you haven't done the deep work. You haven't done the core fear work. You've kind of done ERP to function. And I call this like a fear extinction model, right? You can use, if this cup's contaminated, I can do ERP touching this and not washing my hands until the coffee cup's not contaminated. But that's an exhausting process if I have to do that for every single thing that is or becomes contaminated in my life, versus if I do ERP for this cup being contaminated, I'm still going to do the exposure and not wash my hands, of course, but I also need to figure out why, what is the core fear, right? Why do I think that cup's contaminated? And am I leaning into that fear as well? Because if I actually address that fear while using that cup to, as the way of doing ERP, I won't have to play this game of whack-a-mole because I actually get it all the way. So I always give the analogy of, like, if you have weeds in your yard and you take a weed whacker, like, it looks good, it looks nice for a day or two until the weeds grow back. And actually when they grow back, sometimes they multiply because we've put new spores everywhere, versus if we actually pull that weed and see the root coming back. So are you using ERP to be able to function and to put that trigger or intrusive thought or that specific contaminated item at bay? Or are you actually using ERP and getting to the root so that it doesn't give you or feel like this game of whack-a-mole?
Yeah. So, actually, Liz, I have submitted and considered submitting about whack-a-mole OCD a few times for the conference. Maybe it's something we can think about next year.
But yes.
Y'all two got to do it.
Would love to do this because this is the problem that comes up. So the reason I wanted her to go first was because, quite frankly, that is the main answer. The only time that I will generally make medication changes based on whack-a-mole OCD is if the therapist tells me that, again, that the person can't even do the ERP to be for as Liz says, the functional aspect of it. So they can't even do the ERP for the coffee cup, much less the core fear. But if they can do the ERP for the coffee cup, but they're just kind of ignoring the core fear, generally I'm going to say I can add a med if you want to, but more ERP is really what you need. Usually the medications I add most often nowadays, if you're on the max dose of clomipramine, they generally add one of the glutamatergic medications would be, typically what I would add or recommend. But again, this is mostly an ERP answer most of the time.
Well said. Ali at 1242 says, what other medications besides SSRIs are out there cannot tolerate an SSRI? So I know we talked about clomipramine, we talked about SSRIs and antipsychotics. Is there any other class of medication that's been found to be useful for OCD if somebody is struggling to tolerate an SSRI?
Right. So if you cannot tolerate an SSRI, number one, we try clomipramine, which acts like an SSRI, but is somewhat different. Often people can tolerate the very different side effects that clomipramine has. If people can't tolerate that, there is one SNRI called venlafaxine that has some efficacy with OCD. And so not all the SNRIs in general, but just that particular SNRI is something that you can try. If you even can't tolerate SNRIs, because quite frankly, let's face it, they're very similar to SSRIs, I you can sometimes use some of the glutamatergic medications. So these glutamatergic medications are usually used to augment SSRIs. Unlike the antipsychotics, like we talked about earlier, some of them may have some efficacy all on their own. And there are medications like memantine, riluzole, and some other types of medications that may have some efficacy, again, outside of augmentation of SSRIs. So that would be my step there as well. And again, you have things like TMS that you can try as well. And if we want to go on, there is data to show that people like this who don't do well residential treatment for intensive ERP can help.
Yeah, I always say, like, I really continue to, I think I get a lot of questions about, well, ERP and medication just doesn't work for me. And my question is always like, I want to know more about the ERP you received. I want to know more about, were you ready and willing to do ERP? And also, were you on the full dose of medications, and did you give it enough time? Because actually, more often than not, when I hear folks say that, some of those things actually weren't true or hadn't happened. And with those simple changes of like, oh, it's not that ERP didn't work, it's actually that I needed a higher level of care, like residential, or, ERP was still what was going to work. It just wasn't going to work on an outpatient because of my severity level, right. So there's a lot of ways for us to augment the most evidence-based interventions to be most helpful for you as well.
I'll always remember I was at a conference and Dr. Janicki, rest in peace, somebody stood up and was like, I've been on every SSRI and they haven't worked for me. And Dr. Janicki looks at her and goes, how old are you? And please don't take offense. And she's like 21. And he's like, when did you start seeing a psychiatrist? And she was like, about 19. And he was like, I don't think that that's what happened. I think what happened is you moved through them too quickly. About how long were you on each medication? And she's like, about 3 weeks. And then if it didn't work, my psychiatrist moved me. So I always tell people, I know taking medication, Liz and I have been there, right, is a grueling process. But once you find it and you're on the right dose, it works. So stick with it. That's hard. I just wanted to answer Lisa's question because this is a general question. She says, how can I get a link to the playback? It's at 12:49. Of this for my patients. It's an excellent topic as we try to help my sister with OCD. So for clinicians out there that want to share this with their patients, for people that didn't get the beginning part, etc., always remember you can go to IOCDF's either YouTube page at /IOCDF on YouTube, or here on Facebook, go under videos or lives, and they can watch this back. So
I want to clip, I already took a note because I want to clip the part, Dr. Hudak, where you talked about antipsychotics not being a treatment for OCD, but like what augmentation actually means and the way it should be, because I think that was a really important takeaway. But thank y'all so much for today. I know we only have a minute, so final words so that we can all wrap up. I'll start by just saying that treatment works and help is available. And sometimes we need to, the first treatment you get needs to be changed or adjusted to best fit your needs. But the reality is that OCD and OCD treatment, a combination of effective medication and behavioral therapy, has incredible outcomes for a mental health disorder. So don't lose hope, and just make sure you find the right help, the right clinician, and the right team. Chris, we'll have you go and then let Dr. Hudak wrap it up.
Yeah, my only final thought is, Dr. Hudak, I'm sorry, but we're going to have to ask you to come back. You're so good.
Yes.
Liz and I are always like, because you got through all our questions. There was one live question we didn't get to that I put at the top of our list for next time we have you, but you did so excellent. You answered so much. And I always hope that clinicians and people watch our lives, especially this one, because I think you answered so many of those like top questions that Liz and I and other clinicians get constantly, and not all psychiatrists are generous with their time. So unfortunately, you're stuck with us. You'll have to come back. So hopefully that's okay.
Thank you for having me. I'm more than happy to come back. And my final statement is, again, there's always hope. I don't know that I've ever seen someone come to me and I said, well, everything has been tried, there's nothing else we can do. That just doesn't happen. There's always something.
Love that. Help and hope are always available. Thanks, y'all. Visit iocdf.org/peace of mind to submit questions. And of course, iocdf.org, register for the conference. Can't wait to see y'all there.
End of July, Orlando, in the coldest time of the year, baby. See you at the conference.